Now let us see about management of primary angle closure glaucoma. First one is the provocative test, where we record the baseline IOP of the patient and then they are made to lie in a prone position in a dark room for 1 hour. Then the patient must remain awake so that the pupil will remain dilated. After 1 hour, IOP is again measured. If the IOP change is greater than 8 mm of Hg, then it is considered diagnostic. Then mydriatic provocative test, where there is weak mydriatic like tropicamide or amydriatic and a myotic like 10% phenylephrine and 2% pilocarpine may be used to check the IOP, and if the difference is greater than 8 mm Hg, then they are considered positive for glaucoma. And then anterior segment imaging, ultrasound biomicroscopy is the gold standard to find out the plateau iris and the ciliary body malformation. Then anterior segment OCT is also useful to determine the amount of angle closure. Now let us talk about the treatment of angle closure glaucoma. First is the prophylactic laser iridotomy (PLI). If the angle is greater than 270 degree of the iridotrabecular meshwork contact, then they are considered to have the angle closure glaucoma. Defining criteria for angle closure glaucoma is iridotrabecular meshwork contact is greater than 180 degree of angle, IOP is elevated or pars is present, optic disc should be can be normal and visual field can be normal. Then subacute primary angle closure glaucoma, the IOP is between 40 to 50 mm Hg and lasts for minutes to 1 to 2 hours. Risk factors include physiological mydriasis, physiological shallowing of the anterior chamber, and pharmacological mydriasis using certain drugs. Clinical features of subacute primary angle closure glaucoma is unilateral transient, means temporary blurring of vision, colored halos around light. Then headache, broache and eye ache on the affected side. Treatment for this is laser peripheral iridotomy. Differential diagnosis of colored halos in primary angle closure. The colored halos are formed due to the accumulation of fluid in the corneal epithelium and alteration in refractive index of the cornea (LMLA). Patient gives history of seeing colors in spectrum of rainbow. They see colors like in a rainbow, red outside and violet innermost, while watching a lighted bulb or the moon. In purulent conjunctivitis, we can eliminate the halos by just irrigating the discharge. But in glaucoma and immature cataract, we perform a test called Finchem's test. If the stenopic slit is passed across the pupil in this test, during this test, glaucomatous halo will remain intact, but the halos due to immature cataract are broken down into segments. This is called as Finchem's test. Here you can see the picture given, Emsley-Fincham test demonstrating breaking up of halos. Now next is acute primary angle closure, which is due to the pupillary block. Clinical features or sudden onset of severe pain that radiates, nausea, vomiting that may lead to migraine, impaired vision, redness, photophobia and lacrimation. Signs include the lids may be edematous, conjunctivitis chemos then congested, cornea edematous and insensitive, anterior chamber is shallow, aqueous flare can be seen in anterior chamber, hyperosmotic agents to allow the gonioscopy angle to be seen when the cornea is very cloudy. Pupil will remain semi-dilated due to the ischemia or paralysis of the sphincter muscle. Optic disc remains hyperemic and edematous. We'll see diagnosis and management in the next video.